Welcome back to Beyond the Patterns. So today I have the great pleasure to introduce Dr. Christian Baumgartner, who is currently heading the Machine Learning for Medical Image Analysis group at the University of Tübingen. Christian completed his PhD in 2016 under the joint supervision of Professor Andy King and Professor Daniel Rickert at King's College London in the School of Biomedical Engineering and Imaging Sciences. He further pursued his research interest in machine learning for medical images as a postdoc, first at Imperial College London with Professor Daniel Rickert, then at ETH Zurich with Professor Ender Konukoglu. Christian worked then as a senior research engineer at PTC Wulforia Zurich for a year before joining the University of Tübingen in his current role in February 2021. So today I have the great pleasure to announce a presentation that is entitled The Next Decade in Automated Medical Image Analysis. And I actually did this recording when I was traveling, and you can see that during the Q&A session I'm actually walking in the streets of the wonderful town of Leeds. So I hope you enjoyed the presentation, the Q&A session, and I'm very much recommend having a look at this wonderful presentation.
Yeah, thanks, Andreas, for the introduction and also for inviting me. I'm very happy to have this opportunity to talk to you guys a little bit about my research. So as Andreas already mentioned, I had this sort of break in my academic career. So recently, I've kind of been thinking a lot about, what we should be doing and what is actually kind of missing and what we have already done. Well, before we move on, so just briefly, so in this talk, I want to, on one hand, show you some of my past research, speak about some things that I perceive to be limitations of the field in general, and then maybe try to give a little bit of a perspective. So I think this quote has become quite famous in the meantime. So Jeff Hinton in 2016 said that people should stop training radiologists now. It's just completely obvious that within 5 years, deep learning is going to do better than radiologists. So I imagine he has probably come to regret this quote by now a little bit. But it is actually now exactly 5 years since he made this quote. So maybe it's a good moment to kind of reassess where the field is at this point and what the future perspectives are. So I want to start with this Gartner hype cycle. I don't know, maybe some of you have heard about this already. So Gartner is a consulting company, a technology consulting company. And they came up with this sort of typical trajectory of hype that many technologies undergo. So I think there is a lot of criticism also about this this chart. So take it with a grain of salt, but I will try to sort of use it as a red thread through this presentation. So what happens often is that there is a technology trigger, like let's say the advent of deep learning, and then there is a peak of inflated expectations. Then all of a sudden it doesn't work, the bad press starts, the public gets on the other side of the argument, and there is this trough of disillusionment before you kind of make the technology work really, and you end up in this plateau of productivity. So a good example is in 1995, everybody was talking about interactive agents, chatbots, and things like this, or intelligent assistants. And there was a huge peak in 1995, and then Microsoft implemented this assistant, this Clippy guy. I don't know, maybe this audience is too young to remember, but this was a complete failure, basically. Everybody was annoyed about this. And this interest in this sort of interactive assistant technology stopped until very recently. And now we have, Siri and all of these things that kind of work, or at least better than this guy did. So yeah, obviously, I think medical image analysis is undergoing something similar, and I will be talking about this a little bit. So as I said previously, I want to explore how machine learning can be used in medical image analysis. And since I've been thinking a lot about this, I want to give you a little bit of a structure that I personally use to categorize research. And then I want to try to make some predictions about the next decade. And keep in mind, this is a quote by a famous baseball player. It's tough to make predictions, especially about the future. So, we're all kind of guessing at this point. Okay, so in what ways can machine learning help with medical image analysis? So starting at the beginning, I think it can help with the image formation process. So kind of reconstruction and so on. It can help with the image assessment. That would be the next step. So, making segmentations, things like this. And it can help with population modeling. By this, I mean, extracting imaging biomarkers and coming up with explanations for diseases and things like this. And I think this last point actually has huge potential and is not explored very much in the medical image analysis community yet. But actually, for the scope of this talk, I want to focus on the first two, on the image formation and the image assessment parts. So to go into this in more detail, by image formation, what I mean. So we can try to speed up the acquisition process. We can try to reduce potential dose, such as in CT. We can also use it to detect artifacts, such as motion artifacts and things like this. And we can try to account for these artifacts using machine learning. The sort of clinical motivation for these things are a better patient experience if we can reduce scan times. For example, MR is a classical candidate where we hope to acquire the images much faster, so the patient doesn't have to sit in the scanner for so long. We can aim for better image quality, especially for acquisition processes that are limited somehow. Again, I think MR is a good example because we have a physical limitation to how quickly we can, excite the pulses, the spins. So maybe we can try, maybe there are some acquisitions that are too long to actually do, but maybe with machine learning, we can figure something out. We want to lower dose exposure, such as in CT, to reduce cancers that result from CT. It's actually estimated that 1 in 2,000 CT scans later ends up leading to cancer. So it's not a huge problem, but it's also not a small problem. And of course, there are financial considerations, such as better scanner utilization. So those are the sort of clinical motivations for working on the image formation process. For the image assessment, and that's probably the most studied area currently by the MICAI community, I think perhaps the first thing that comes to mind is diagnosis of diseases. Also detecting and localizing disease or organs or other things. We want to perhaps predict stuff such as the survival or whether the person will develop Alzheimer's disease or something like this. And we want to quantify. Basically, we want perhaps to measure how big an organ is or whether a tumor is growing in size over time or not. And many of these things are, routinely done by humans, but are very time consuming. So the sort of main medical motivation, I think, at this point is basically that this amount of data that we're acquiring is constantly growing, and the number of radiologists that we have to evaluate those data is not growing fast enough to keep up with the demand. These numbers that I'm showing here, they're from something called the UK Radiology Workforce Census. And they just have some very nice statistics. So you can see that currently the increase in images is much larger than the increase in radiologists. And it is estimated that there will be a 31% shortfall in radiologists by 2023. But there's more than just, helping to process the data more efficiently. And I think a big factor is to help people who look at these patterns, so radiologists, histopathologists, ophthalmologists, all these people, we want to help them to make fewer mistakes. This is actually a really big problem. Not many people realize. For example, it's been shown that in 25% of cases, pathologists don't agree on a breast cancer diagnosis based on such histopathology images. And it was also shown that pathologists who use an AI tool, can actually reduce their error rate by up to 85%. And this applies, this general thinking doesn't only apply to pathology, but to all of those pattern analysis problems, I think. So AI has huge potential to add some consistency and some reduced error rates to this process. And by the way, I just want to mention, if you do have questions, just ask. It's always a little bit weird in these talks. You kind of talk at your computer screen alone in your office. So if you have a question, let me know you're here and just ask directly. Okay, and I think the last huge potential of these technologies is that we can actually go beyond what humans can do. And there was this really interesting study recently by Poplin et al., as it's not so recent anymore, 2018. And these guys showed that you can actually detect things from fundus images that the medical community did not know was there. So a neural network can identify age, gender, blood pressure, and cardiovascular risks from these images. Cardiovascular risk means they can basically predict how likely you are to have a major cardiac incident, such as a heart attack or something in the next, I think, 5 years, which is pretty remarkable. And the most remarkable thing about it is that, first of all, doctors didn't know this information was in those images. And secondly, doctors cannot do it themselves. So these changes are so small that you kind of need an AI to reliably extract this information. Okay, so is the problem already solved? Because we have been seeing a lot of these headlines recently. We've all read papers like this, which all say, yeah, we have human level, we're at the level of dermatologists, human level, you get the point, right? So what are we even still doing? Isn't the problem already solved? And in reality, perhaps unsurprisingly, it turns out, no, the problem is not solved. In particular, recently, there were these 3 very big meta-studies. This one was published in the Lancet based on 82. It's a meta-review of 82 papers that claim, human level performance. This one is another meta-study of 81 papers. And this is a very recent study that looks only at tools for breast cancer screening. And all of them basically find that if you look at all of the clinical studies there are, none of them actually show that we are outperforming humans. They're all flawed in certain ways. For example, they're not evaluating in clinical environments. They all, many of them have biases in the patient selection. They're not evaluated on different data sets in different hospital sites and things like this. So the overarching conclusion is that the true diagnostic power of AI remains uncertain. It doesn't mean that AI doesn't work. It just means that none of the studies that have tried to show that AI adds a clinical benefit have actually really shown a clinical benefit, which is sort of remarkable if you think about it. If you think how many papers, how much work goes into this, and really there isn't any strong evidence right now that AI is really helping with diagnosis or, yeah. So that's, something to think about. There's another interesting paper, this survey by the American College of Radiology, which interviewed 1,427 participants. And they found that, a bit more than 33% of radiologists report that they're actually already using AI in their practice, which surprised me a lot. Yeah, I thought it would be far fewer than this. So it's actually already kind of infiltrated the market to a substantial degree. However, the interesting thing is that almost 95% of people say that the performance of the algorithms they're using is inconsistent. So they're not happy, with the performance. And this article also mentions that the vast majority of FDA-cleared algorithms have actually not been validated across a large number of sites. And this is kind of reflected in what the participants say, that they would have wanted a better reporting of performance. So this exactly matches what the meta studies, I think. So basically, radiologists are not getting out of the software what they wanted to. They're not working as well as they thought. So let's quickly go back to this Hive curve. So in my personal opinion, I think we're actually right somewhere here. Maybe already on the way down, because I think we're slowly realizing we have these meta studies that say, it's actually not working so far. And I think we're very close to something, to a headline like this, what happened in autonomous driving, which in some ways has a parallel development. I think there was a huge hype and now people are getting kind of skeptical. You have all these news stories of accidents. Tesla sued by Texas cops after Model X on autopilot slammed into 5 officers. And especially because the FDA is not really on top of approval of these technologies. I think they're also lacking the technical competence. FDA being the Federal Drug Administration. So in Germany, the equivalent would be the TÜV or something like this. I think we're very close to seeing a headline like this for medical image analysis. Siemens gets sued by patients for misdiagnosing disease or something like this. So what is the main reason why machine learning is not really fulfilling its promise at this point? So I think on the machine learning side, really the main reason, if you kind of think about it, is robustness. I think that's the main key ingredient that's missing, because the stuff that we're developing is just not robust across sites, across patients, across scanner models, and so on. So these neural networks that many of us are working on are just known to be extremely brittle. And I think reason 2 is that so far, actually, most research is kind of dealing in this human versus AI scenario, while not enough research goes into how can we create human AI teams that work on these problems collaboratively. I think there's also a huge problem on the clinical evaluation and regulatory approval side. So as these meta studies were showing, a big problem is that none of these studies are technically accurate. So they're not doing the evaluations necessary to prove what they want to prove. So I think we need better clinical evaluations. That's what follows from this. And regulatory bodies also need to keep up with the technology. I was saying that, many of these technologies have not been evaluated across multiple sites. for example, that's something that clearly would need to have to be a requirement to get FDA clearance, in my opinion. In my opinion. So I think also on the regulatory side, we need more developments, and to some degree, this has to be a dialogue, right, between machine learning researchers and notified bodies. So let's talk about more about the machine learning issues. So how can we solve these problems on the machine learning side? So one way is obviously to build inherently more robust methods, which is easier said than done, but I think it's a big question in medical image analysis research, as well as fundamental machine learning research. But I don't think it's the only way we have to tackle the problem of robustness. Another way is improved uncertainty estimation and out of distribution detection. So if those methods are not robust, at least we know when they don't know. So we have a sort of red flag when something goes wrong. I think another approach would be, rather than work on this domain generalization, that we have one product that works on all of the hospitals. Another solution that we could use is to build solutions for each practice individually. And it's not so unrealistic. In fact, in this same ACR study that I was telling you before, it was found that 10% of radiologists actually already developed their own custom solutions in their own practice. So I think the research that's required there would be to develop methods with better data / label efficiency to empower individual practices to build methods tailored to their personal data. And a big issue that I'm very passionate about is interpretability. A few words about that. So there is this opinion that if you have robustness, you don't need interpretability, basically. So that interpretability is not mission critical for getting these techniques to the practice. And I used to be in this camp. I thought, if we have robustness, if we have uncertainty, we don't need interpretability. And since I've looked more into how these techniques are actually approved, I've realized that, in my opinion, interpretability will be a huge factor in the future. If you want to make an FDA or TÜV submission, for that matter, you have to sort of describe how your algorithm works. And the more convincingly you can outline that, how your method works and what the expected failure cases are and what mitigations you have for those failure cases, the easier it will be, one, to approve, but two, also to kind of show that from a small clinical trial, you can extrapolate to a larger population. Because if you have no idea how it works under the hood, it's very difficult to make a claim that you make a study on one hospital or on 2 hospitals, and now you expect it to work on all hospitals. Note that drugs are very different, right? So for drugs, we kind of know how they behave. So if you have a big study in a couple of hospitals, because we sort of know how they biologically work, we can draw conclusions from that. Okay. So in the following, I want to talk about a few research topics that I have worked on in the past. The first one is robust MR reconstruction. So to quickly motivate the problem. So MR works by acquiring data in this frequency domain in the K-space and basically doing an inverse Fourier transform to get to the image domain. So I'm sure many of you intimately know this, but just so we're all on the same page. So this can often take a long time, and to speed up the process, we can undersample the K-space. We can basically only acquire the K-space partially, but if we do nothing about it, we end up with these aliasing artifacts, right? So what can we do to prevent these aliasing artifacts? The sort of naive approach is to simply build a neural network that takes in undersampled case-based data and outputs the reconstructed image. And that's basically what Zhu et al. Did in this Nature paper. However, it's a bit problematic. It was, I think, maybe the first approach who did this. But the problem is that, first of all, it's only going to work for one case-based undersampling pattern. So it's very limited by your training data. And the other reason is that it doesn't really have guarantees that what comes out is somehow related or consistent with the case base. So we came up with a slightly different approach for this. So first of all, we reformulated the medical image reconstruction problem as a Bayesian model. So we know how the case base Y is generated from the image M via this encoding operator, which includes, the undersampling, the Fourier transform, all of that, plus some noise, like thermal noise or scanner noise that we can also model. So if we want to express this as a probability, we can say the probability of the case-based data given the actual image that we don't have yet is a normal distribution with the mean here and some noise, sigma. So this is our observation model, but it's not what we want. What we want is the opposite, right? We want the probability of our image M given the case-based data. This is what we want. So we can use good old Bayes to switch these terms around. We end up with this. Since we only want the maximum the maximum a posteriori distribution, this guy down here doesn't depend on M. So if we do a maximization, we can basically get rid of this guy. And also, log is a monotonic function, so it doesn't change the maxima. So if we do the whole optimization in log space, we can turn this multiplication into an addition. And this can be basically viewed as a, sorry, I need to move my Zoom window panels around a bit. Okay. So we have here a data term that measures our consistency of this image with the case-based data. And we have a regularization term. And this fits very nicely with prior work, actually. So we have this prior model, this manifold, and we have this gray blob, which is all reconstructions that are consistent with the case base. And prior models actually can be anything. For example, we can have this total variation regularizer, which is not our invention, which is a very standard way to reconstruct an MR image with a total variation regularizer. PM can be something like a kernel density estimation. You can use PCA. You can use dictionary learning. There's lots of things how you can develop a prior. However, what we did, what is novel in this work, we learned the prior using a variational autoencoder. So if you're not, I won't go into detail, but a variational autoencoder is basically a generative model where you can assume that you kind of assume that your images M live on a lower dimensional manifold. And so you can sample from this manifold to reconstruct, to kind of cover the whole distribution of your high dimensional image data. And you can learn this in this sort of autoencoder fashion. So here are two MNIST digits, but in our case, this would be all possible MR images. So we basically have a training data set of MR intensity images, and we train this to get basically a expression for the probability of any image that we give it. And using this variational autoencoder, we can plug it into our formulation to find the correct solution. And the prior is, because if you are familiar with the variational autoencoder math, is actually only a lower bound. So the prior is sort of approximate, and because of the bound, and also because of problems actually learning the exact prior. So it's only an approximation. So we have here this blob of all image reconstructions that are consistent with k-space, and this manifold of all possible MR images that are the distribution of all possible MR images, basically. And we need to find a sort of intersection. So what we can do is differentiate and project. So we do this iteratively. We kind of take a few gradient steps towards the prior. Then but now it's not consistent with the k-space anymore, right? So we map it back to the k-space. Now we take a few gradient steps to the prior again. Now we make it consistent with the k-space again, and we iterate. And so here you can see a little animation of how that looks in practice. So when it loops around in the very beginning, you see those aliasing artifacts. And then as the optimization continues, you see it getting more and more consistent with the prior, with real MR images. So we found that this works better than standard approaches such as total variation, and also better than some other neural network-based approaches. It's easiest when you look at the close-up. So in total variation, you get these overly smooth reconstructions. And this is ours. So you can see that it's basically the sharpest and the most realistic looking. And what's cool about this is that you can actually, it's independent of the sampling pattern, of the k-space sampling pattern. So we can, without retraining the model, immediately reuse it with a radial sampling pattern, with a Cartesian sampling pattern, the spiraling sampling pattern, whatever we want. Okay. Now I want to present another work about uncertainty quantification, but perhaps, if anybody has a question at this point about the MR reconstruction stuff, I'm happy to talk about it now, or we can also talk about it at the end. Just let me know. Okay, so I will move on to the next part. So this part is about segmentation of the prostate in MR. So if you have an MR image of the prostate like this, and you ask a doctor to segment it, you get something like this. And if you ask another doctor to segment it, you get something like this. And if you ask 4 more doctors to segment it, you get 4 different solutions. So this is maybe a problem that some of you encountered in your own daily work. Essentially, there are different factors leading to this. So on one hand, the ground truth may not be completely clear, because along these boundaries, it's just very difficult to tell where the structure actually ends and where the structure does not end. So you kind of need your medical knowledge to guess where the boundary is. And different doctors do this in different ways. And especially here, I think there is also a component of annotation style. Different doctors just do it differently because they learn differently, maybe. But this is problematic if you want to train a neural network, because what is the ground truth, right? What is the correct solution? So in this work, we tried to move away from this idea that there is one correct solution and define the correct solution as a distribution. So there is a correct distribution of segmentations given an image X. And instead of training a network to learn a single distribution, we want to train a network, a single segmentation. We want to train a network that learns the whole ground truth distribution. And again, we did this using a sort of variational autoencoder approach, but in this case, it was hierarchical. So this is the graphical model. So this lowest level ZL is responsible, given an image, to create a very low resolution segmentation. And then the next higher level adds some more high frequency components. And this continues for 5 levels in this case. So here you always see the residual, what is being added to the segmentation to make it better. But because this is basically a graphical model, we can just apply the variational autoencoder math exactly the same as in a simpler case. So we can use this QZ given segmentation and image to approximate this distribution of the latent space. Yeah, so I won't go into the math in detail. If you want to chat about this in detail, you can let me know, or you can ask me in the end. But basically, what we have in the end is a lower bound on the actual probability of a segmentation given X. And it's quite a long equation you have here, but the individual components are easy to understand. So first of all, we have the distributions of the latent space. So first of all, we have the prior P of Z given the respective layer below it. So this is these terms. We have the posterior given by these terms. And exactly as in a normal autoencoder, except we have more of them. And we have the likelihood, which is basically the reconstruction. And what is different here compared to a normal variational autoencoder, apart from the hierarchy and that you have multiple priors and multiple posteriors, is that everything also depends on X. Yeah. So the posterior as well as the prior as well as the posterior depend on X. And we can basically take these equations and translate them into a neural network architecture, which is what we did here. We started with the idea that our result should kind of look like a U-net. And so the implementation is a sort of U-net, where we have the posterior here, which outputs the distribution of these latent variables, Z1 to Z3, and prior that outputs the posterior of these variables. You can see the lowest level only depends on X. The next level depends on X and the lower level, and so on. And it just outputs for each level a mean and a standard deviation. Then we sample from these layers, and based on the sample, reconstruct the whole thing into a segmentation. So this part here is actually just a normal decoder, like you would have in any network. To sort of intuitively understand what's going on is, so up here we have, into this network comes an image and a segmentation. And based on this, so both of these things go into the decoder, right? Based on this, we try to reconstruct the segmentation. And at the same time, this prior network is trying to imitate this guy through the KL loss that links each of these nodes. So during inference time, when we don't have the ground truth segmentation anymore, we can just throw away the top network, and can use this as an end-to-end segmentation network that inputs an image, outputs some random variables. From this, we can sample and reconstruct, let's say we can sample 100 times, then we can reconstruct 100 different segmentations that are consistent with this image. Okay, so here are some results. So this is a GIF of the expert annotations. And here you see annotator variance of so this is basically the ground truth distribution in a way. And here is a GIF of samples from our model. And you can see that as kind of qualitatively, they behave very similarly. And also this variance map looks kind of similar, with the biggest variance being in this area. And yeah, we of course also quantitatively evaluated this, but I won't show you the numbers here. Another kind of intriguing property of this was that it was actually more robust as well. So this is a probabilistic unit when you input a random bar into the image. And remarkably, if you do this with our model, it was kind of robust to that sort of massive intervention. So it's not correcting exactly the right thing, but it degrades more gracefully than the other model. Okay. So interpretability is something I care a lot about, and it will definitely be the focus of my future work. But I think I will skip over this nevertheless, because in the interest of time, basically. So to summarize, so what will happen in medical image analysis in the next decade? I think there will be a big disillusionment as the hype will, remain unfulfilled. The lagging regulatory approval strategies will create a dangerous situation that will change the opinion of the public on this technology. And keep in mind, this is me making predictions, so who knows what will happen. But I think soon we will be seeing headlines like, is this technology dangerous? Then as the technology matures by the contributions of basically us, of the medical image analysis community, we will develop more robust, more uncertainty aware, more interpretable methods. And machine learning will slowly become a standard diagnostic aid and will ultimately lead to real patient benefits, which I think at this point it is not yet doing. So this concludes my talk. Thanks a lot for your attention. A little self-plug. I am looking for a PhD in interpretable machine learning. So if you are interested, you can reach out to me. And yes, let's discuss some questions or some other things you wanted to talk about.
Christian, thank you very much for this presentation. I think it was awesome. You did a very good job. And I think the questions that you're raising, that you're addressing, are very, very important for the field. So this is something that will probably really be the topic of research for the next decade. So I completely agree with that.
Oh, thanks a lot. Yeah.
It's really cool what you're showing. And in some applications, the analysis, also the traditional modes of analysis, for example, in the histopathology, what you've been showing, do you think that the reliability issue is partially also because it's just a lot of data that has to be processed? And the way that it's processed right now, it's just too much for a single pathologist to go through the entire whole slide in order to get the result. Do you think this is also one of the problems? Absolutely, yeah. I think that's probably the main problem you're mentioning. So you're talking about the point I was making. Let's see, on this slide, right? So exactly. Yeah. So as you are saying, so these images are absolutely massive. So it's very difficult for pathologists to not miss anything. Yeah. So there may be a very small area that's cancerous, and maybe they just miss it.
And I think similar problems apply to other things as well. For example, in CT, one standard thing they do is if they do a lung CT, they always check whether there are any nodules that are suspicious. And it's just so difficult to go through the CT slide by slice by slice and not miss anything. So I think this is definitely a huge factor. Yes, I agree.
Absolutely. So you said that already more than 30% of radiologists use AI. Do you know what kind of AI they're using? What kind of algorithms? Because I think that's super interesting. I'm also quite surprised to see that the number is so high.
Mm-hmm. So I was surprised, as I was saying. So it's not just for image analysis. I have the paper here actually. So of those who are using AI, 50% are using it for interpretation, 15% for work list management, around 10% for image enhancement, around 10% for operations, whatever that means, and 10% for measurements. And it's mostly FDA approved technologies, basically. So there are a bunch of these softwares out there. And apparently they're managing to sell their stuff to practices. So I think the most used modality was for breast cancer screening. I think most people use it for that. Also for brain hemorrhage detection in CT. Yeah. I can send you the paper later if you're interested.
Absolutely, that's interesting to see. I thought it's most for analysis and measurement, but that's really a variety of topics that it's been used for. So you mentioned that at some point AI will create a failure and will probably start a lawsuit. I think that there are also FDA cleared products that create problems or created problems in specific settings. And I think I remember that also for iterative reconstruction, the extreme dose saving setting of one of the vendors actually caused small tumors or small lesions to disappear in CT images. So I think it's already the case that not just AI algorithms fail, but also some of the classical methods. So well, what do you think about that? So, I mean, iterative reconstruction hasn't disappeared, but of course it has to be done with more care, right?
So first of all, I think these reconstruction applications are perhaps the most critical because the humans cannot kind of fact check it so well, because a human cannot look at the case space and say, this reconstruction looks unreasonable, or it's extremely difficult to look at the individual projections of a CT scan and assess whether the 3D reconstruction makes sense or not. So, so first of all, this is a very critical topic. I did not know about these problems that you mentioned. So, is this software that is in clinical use, or was this a sort of case study?
Well, this really happened in a clinical product, but it's only extreme dose settings. So this is actually something that then simply the vendor discouraged from using. So they said, don't use it in this extreme setting, use more reasonable ones. And then, of course, the tumors were present.
Okay. I didn't know that. That's very interesting. Maybe that's another topic for offline discussion, but I would be interested to know more about this.
So this also brings me to one topic that, you know, we had sometimes also persons from reconstruction and that trying to fuse the image reconstruction with the image analysis. And one of our presenters went so far to say, maybe we don't need that image anymore. Maybe we just scan the case-based samples that are relevant for the diagnosis, and that's it. So that would be much faster, much more efficient. What do you think about that? Yes.
What I think about this is that I mean, it could be very promising because you may be getting results faster, but you would have to be extremely confident in the function of your algorithm because you actually don't make it more interpretable, you make it less interpretable. Because by removing this intermediate step of being able to look at the image, you remove a potential fail-safe mechanism, right? So I don't know. It remains to be shown whether this is a good idea or not. I think if you can be extremely confident in your algorithms, then this would be very promising. But at the stage where we are now, so I wouldn't be very happy if my radiologists, when I get a scan, wouldn't actually look at the image, but would only directly kind of get a prediction from the case space.
Yeah, maybe this can also be with a different application. You know, if you're running for routine diagnostics and you just want to rule out the positive cases, like it's not cancer, then you might be okay with that. But if it is cancer, you probably want to acquire the remaining case-based logs to get the image, right?
That's true, yeah.
It's probably different tools for different applications.
Mm-hmm. Another, I guess, what would be a related application is to detect whether there are motion artifacts or not in case space, so that you kind of can abort the imaging before you reconstruct, just so to save time.
Absolutely, and that has also a very low risk, right?
Exactly,
if you do the decision in the worst case, you just spend 2 minutes more scan time, but you're not missing a cancer or have a severe consequence in the treatment.
Yeah, true.
Absolutely agree. Christian, I think this was a really interesting presentation. I enjoyed it a lot. You're doing really cool work. I'm really sorry that we couldn't see stuff on interpretable AI, because I think that's also really cool work that you're doing. But at least let's put the references to your works in the description here of the video. And I would like to thank you again for being able to present here. Really cool stuff. And I'm very much looking forward to future work presented.
Yeah, thanks a lot, Andreas. It was a pleasure to join your seminar.
So I hope you enjoyed this presentation as much as I did. Christian really has some very, very nice ideas, some very smart ideas, what he will be probably researching on in the next couple of years. So I think this is really inspiring research. If you have additional questions, then of course, please ask them either in the comment functionality, or you interact with me or Christian also on social media. So I think this was really a wonderful talk. And if you liked it, then I would invite you to join us again in one of the next episodes of Beyond the Patterns. Bye-bye.